All right, so this video is going to be 50 high-yield GI questions. The way that I find these questions is I go through the NCCPA blueprint for the Pance, pick a few questions from each topic, and I try to pick the things that I feel like are the highest yield, the ones with the highest likelihood that you'll actually be asked on the Pance or on your exams. So let's go ahead and get started with this. First question, describe Boas sign in acute cholecystitis. So Boas sign in acute cholecystitis. This is going to be referred pain. It's generally just inferior to the right scapula, and it's seen in acute cholecystitis due to phrenic nerve irritation. So you have the phrenic nerve that's running from all the way down near the gallbladder, all the way up here to the shoulder and into the back. So you have irritation from the inflamed gallbladder, and that's radiating all the way up here. So that's why sometimes you'll have a patient with acute cholecystitis that actually has right upper back pain. So be aware of that for your exams and for your actual clinicals when you're diagnosing and out there seeing patients. Describe Charcot's triad seen in acute cholangitis. Describe Charcot's triad seen in acute cholangitis. So this is going to be three things that you'll see: fever, right upper quadrant abdominal pain, and jaundice. So it's actually not very common to see all three in patients. Only about maybe half of the patients that have acute cholangitis will actually have all three. And remember, if they have hypotension and altered mental status in addition to these three, that's known as Raynaud's pentad. So be aware of that as well. Question 3. What type of gallstone is seen more commonly in bacterial and parasitic infections, as well as more prevalent in Southeast Asia? So what type of stone is seen in bacterial and parasitic infections, as well as Southeast Asia? It's going to be brown stones. So rice-growing regions of Southeast Asia have a higher incidence of this type of parasite that's known as a biliary fluke that can infect and predispose these patients to brown pigment stones. So anytime you see any type of parasitic infection, bacterial infection, you should be thinking of brown stones. And remember, of course, overall, the most common type of stone is going to be your cholesterol stone. That's about 90% of patients. Question 4, 16-year-old male patient presents to the office, accompanied by his mother. He's complaining of transient episodes of yellowing of his skin. He's noticed it often occurs when he's taking a test at school or recently when he had an upper respiratory infection. He has no other symptoms, and his labs show an increase in indirect bilirubin, but otherwise no abnormalities are seen on his labs. Labs are otherwise normal. What's the likely diagnosis in this patient? So likely diagnosis is going to be Gilbert syndrome, and Gilbert syndrome is a benign condition. Most of the time doesn't require any treatment at all, where the liver doesn't properly process bilirubin. Most patients are going to be asymptomatic outside of these transient episodes of jaundice, and it'll commonly occur during stress, illness, like we saw in the vignette. Lab findings are often going to be normal, except for that isolated elevation in indirect bilirubin. So remember Gilbert syndrome with that transient episodes of jaundice. 5, what is the most common cause of acute lower GI bleeds? Most common cause of acute lower GI bleeds, that's going to be diverticulosis. Definitely remember that one. Question 6, what is the most common area of the colon to be affected by diverticulitis? Most common area of the colon to be affected by diverticulitis is going to be the sigmoid colon, and that's due to the increased intraluminal pressure in that area. The mnemonic that I came up with is eating too many clams can cause diverticulitis. The S in clams is for sigmoid to help you remember the most common area. And then you can see the rest of it. C stands for CT, which would be your first line imaging. C for Cipro, which is the second line PO antibiotic combined with metronidazole. L stands for left lower quadrant pain. That's going to be the most common symptom. Augmentin, first line antibiotic, and then metronidazole, the second med in this combo here. So remember, eating too many clams can cause diverticulitis. Remember a few of the important things you need to know for that. Question 7, what should be suspected in a patient with systemic toxicity like fever, tachycardia, hypotension, and colonic dilation visualized on abdominal radiograph over 6 centimeters? So what should you be thinking as far as diagnosis for this patient? It's going to be toxic megacolon. Anytime you see a combination of systemic toxicity with colonic dilation over 6 centimeters on imaging, should be thinking of toxic megacolon. I always remembered it as, instead of toxic megacolon, toxics megacolon. So you remember that over 6 centimeters of dilation. Question 8, for a patient presenting with bloody diarrhea, left lower quadrant abdominal pain, and a uniform loss of haustral markings in the bowel visualized on barium enema, what should be the first line treatment for the likely diagnosis? So they have bloody diarrhea, left lower quadrant abdominal pain, and a loss of haustral markings on barium enema in the bowel. What should you be thinking here? Well, the treatment is going to be topical 5-aminosalicylate acid, like 5-ASAs. Mesalamine is going to be the most commonly used, and the diagnosis is going to be ulcerative colitis. So you have to look at the vignette and look at your key areas here. So you have left lower quadrant pain, you have bloody diarrhea, and then that very specific finding on imaging, that loss of haustral markings, which is known as a stovepipe or lead pipe sign on barium enema. So ulcerative colitis, this is a very classic vignette. And then your treatment for ulcerative colitis, first line treatment is going to be your topical 5-ASAs. Mesalamine is going to be the most commonly used in that class. So question number 9, describe the findings on colonoscopy in a patient with Crohn's disease. So what are you going to be looking for in colonoscopy in a patient with Crohn's disease? Well, it's two things, two descriptions. And that's going to be skip lesions and cobblestone appearance. In patients with Crohn's disease, you have these discontinuous transmural lesions. So you'll have intermittent areas of normal appearing bowel surrounded by these longitudinal ulcerations, and they're known as skip lesions because they're skipping. Obviously, there's normal area bowel, and then it's interlaced with that normal mucosa. So it's skip lesions, and it appears as cobblestone appearance is the way they describe it. So remember, skip lesions, cobblestone appearance in Crohn's disease. The mnemonic I came up with Crohn's disease, completely discontinuous, which remember, that's how you know it's non-continuous inflammation, those skip lesions. Completely dry, because generally the stool is going to be non-bloody. Completely deep, it's transmural inflammation all the way through the mucosal membrane. And then completely diverse, because remember, it can be anywhere in the GI tract from the mouth to the anus. And that's going to differentiate it from ulcerative colitis, which is normally only in the large bowel. It's not normally transmural, it's normally just in the superficial layers, normally bloody. And then it's normally continuous throughout. So this is different in Crohn's disease, or you can remember it by this mnemonic here. Question 10, Crohn's disease is most commonly found in what segment of the GI tract? So Crohn's disease is most commonly found in what segment of the GI tract? It's going to be the terminal ileum. Terminal ileum. The way I used to remember that is TI makes CDs, like TI the rapper, he makes CDs. So TI, terminal ileum, CD, Crohn's disease. That's the way I remembered it. Question 11. Patient with a history of hyperlipidemia, hypertension, and history of myocardial infarction presents to the office today complaining of dull abdominal pain that increases in intensity after meals. He's lost 15 pounds in the last 3 months. What diagnostic test should be ordered to make a definitive diagnosis in this patient? So the key here is that intestinal angina, that abdominal pain after meals. So what you should be thinking of for this patient is going to be chronic mesenteric ischemia. And the definitive diagnosis for chronic mesenteric ischemia is going to be angiography, so CT angiography. So the other key in this vignette is that history of atherosclerotic disease. So hyperlipidemia, he has had a previous MI, atherosclerotic disease, which is going to be one of the most common risk factors for these patients. And then he has that intestinal angina, pain after eating. Also, remember, they mentioned that he lost 15 pounds. They didn't specify if he was trying to or what the reason was. So we have to assume that it's due to a fear of eating because he's having all that pain with eating. So those are all signs to point to chronic mesenteric ischemia. Again, angiography is going to be your definitive diagnosis for that. So 12, what type of adenomatous colonic polyp has the highest risk of becoming cancerous? So which type of adenomatous colonic polyp, highest risk of becoming cancerous? It's going to be your villus adenoma. It has about a 35 to 40% chance of malignancy. And then you compare it to the other two, which is going to be the tubulovillus adenoma, only has about a 20% risk of malignancy. And then finally, tubular adenoma is only about a 5% chance of harboring a malignancy. So the way I remember that was villus adenoma. I remember a villainous adenoma, because villainous, obviously a villain's bad and cancer is bad. So villainous adenoma, and you remember villus adenoma, that has the highest chance of becoming malignant or cancerous. So question 13, what tumor marker can be used in the diagnosis of colon cancer? What tumor marker can be used in the diagnosis of colon cancer? It's going to be your CEA, or your carcinoembryonic antigen. It's most commonly used of the tumor markers for colon cancer, but it's not very specific or sensitive. It can actually be elevated in gastritis, diverticulitis, really any chronic or acute inflammatory state. It's more effective at evaluating prognosis after surgical resection rather than making the initial diagnosis. So it's one of those things that you don't use that often, but they very well may ask it, and you should just be aware. If they're talking about diagnosis of colon cancer, they want to know the tumor marker. It's going to be your CEA. Question 14, what diagnostic test should be used in a patient with GERD that has developed adenophagia and weight loss? So they have GERD and they've developed adenophagia, so painful swallowing and weight loss. What test are you going to use now? It's going to be endoscopy because this patient has what's known as alarm symptoms. So alarm symptoms, adenophagia, pain of swallowing, weight loss, any bleeding, dysphagia, they can all be suggestive of malignancy in these patients. So rather than what you normally do with GERD, doing a clinical diagnosis or maybe even a 24-hour pH probe, you're actually going to go further because you need to actually make sure that there isn't an involving mass in the esophagus because of these alarm symptoms. So that's the key here. Question 15, what diagnosis should be suspected in a patient presenting with dysphagia to both solids and liquids, as well as lower esophageal sphincter narrowing and an absence of peristalsis distally that's visualized on barium esophagram? So what should be suspected? What diagnosis should be suspected? That's going to be achalasia. Classic presentation is going to be dysphagia to both solids and liquids, which we see in this patient. And then the key findings are on the barium esophagram. The main thing here is that lower esophageal sphincter narrowing, and that's what's known as a bird beak appearance. And we can take a look at that here. So what you have is you have this narrowing down here at the lower esophageal sphincter, and then just distal to that you have the dilated esophagus. And you're also going to have an absence of peristalsis, which you can visualize when you're actually doing the live fluoroscopy. But the main thing here is that this narrowed area of the lower esophageal sphincter, remember, it's clamped down, it's not relaxing that lower esophageal sphincter, and that's the key. And they probably won't say bird beak appearance, so you just need to know if they say narrowing or anything like that, you should be thinking achalasia. Question 16, 10-year-old boy with a history of asthma presents to the office today accompanied by his father complaining of pain and difficulty with swallowing. He's been experiencing this for several months, and his father finds there has been a few occasions where he's vomited during meals. An endoscopy is performed, which reveals stacked or corrugated rings in the esophagus accompanied by white papules. What diagnosis should be suspected? So the key here is the endoscopic findings. The answer is going to be eosinophilic esophagitis. First clue is going to be the history of atopic disease. So asthma, if they mention eczema, and then also they describe dysphagia. You can also have adenophagia. And then finally, the key there is that endoscopy, the corrugated rings or those stacked rings, which we can take a look at here. This is a key to eosinophilic esophagitis. And then also what you might see, which I mentioned in the vignette, is white papules. And what those actually are is they're eosinophil microabscesses. So these patients you can diagnose with endoscopy. And this is a very classic vignette for somebody with eosinophilic esophagitis. Question 17, a patient with history of excessive alcohol use is discovered to have a mass in his proximal esophagus. He denies a history of GERD. What type of esophageal neoplasm does this patient most likely have? So basically what you're deciding here is does this patient have squamous cell carcinoma or is it adenocarcinoma? So let's actually go through that and figure out how we know. So the first thing they mention, excessive alcohol use. This is a key to squamous cell carcinoma. So that's our first clue. Doesn't make the diagnosis, but let's keep going on. He's known to have a mass in his proximal esophagus. Well, squamous cell is found in the proximal esophagus. Adenocarcinoma is found in the distal. So again, another clue for squamous cell. Let's see if we can see anything else. Denies a history of GERD. This may seem like not very important, but it's actually extremely important because adenocarcinoma, the most common cause is going to be Barrett's esophagus, which we know is from chronic GERD. So he doesn't have GERD. So basically, this is 100% as far as a vignette can be to say that this patient has squamous cell carcinoma. So you have to look through the whole vignette, make sure, because almost everything that they tell you is important for a reason. Sometimes they'll put in useless information, but most of the time there's a reason why they list certain things. So this is going to be squamous cell carcinoma. We can take a look here and see squamous cell again is going to be in the proximal esophagus, the upper or middle section of the esophagus, and the risk factors are going to be smoking, alcohol ingestion, where adenocarcinoma more at the distal or the lower esophagus, and Barrett's esophagus is going to be one of the main risk factors here for that. So in this case, it's going to be squamous cell carcinoma. Question 18, a patient presenting with halitosis, dysphagia, and occasional regurgitation of undigested food should have what diagnostic test to reveal the likely diagnosis? So look at the vignette, halitosis, dysphagia, sometimes regurgitation of undigested food. What diagnosis? Well, we have to think of what diagnosis, but what diagnostic test actually make the diagnosis? That's going to be a barium esophagram. So this patient has a pretty classic presentation for Zenker diverticulum, and the key really is the halitosis, because you can have dysphagia from other reasons, but if they ever mention halitosis with the patient, and they mention anything else with dysphagia, you should be thinking Zinker's diverticulum right away. That's always the thing that they use in there to kind of differentiate. And the reason they get halitosis is because the food gets caught in this outpouching they have, that Zinker's diverticulum, and it basically sits there and it ferments, which causes this halitosis. And to diagnose, you're going to do a barium esophagram or a barium swallow, and you can visualize the barium collecting in that posterior outpouching, that diverticulum. So that's the key there. Those things, halitosis is big to actually make that diagnosis, and you'd use a barium esophagram for imaging. 19, what is the first line treatment for a patient with distal diffuse esophageal spasm? What is the first line treatment for a patient with distal diffuse esophageal spasm? Anytime you see spasm and they want a medication, you should always be thinking of calcium channel blockers. That's one of the main medications for almost all types of spasms, whether it's a coronary vasospasm, like in cocaine-induced MI, in this case esophageal spasms. Calcium channel blockers are almost always used for that. They're the most commonly used meds. There's some other antispasmodics that will be used in this case. You may see nitrates, low-dose tricyclic antidepressants, but generally calcium channel blockers will be first line in this type of diagnosis. Question 20, describe Plummer-Vinson syndrome. Plummer-Vinson syndrome, remember this is a triad, so what does a triad consist of? It's going to be dysphagia, esophageal webs in the cervical region, and iron deficiency anemia. So if you ever see Plummer-Vinson syndrome, you should be thinking dysphagia, esophageal webs, which is in the cervical region, and iron deficiency anemia. The way that I came up to remember this, Plummer-Vinson syndrome, you have plumbers inspect clogged toilets. Plumbers inspect clogged toilets stands for Plummer-Vinson syndrome. Inspect stands for iron deficiency anemia. Clogged stands for cervical esophageal webs. And then T, trouble swallowing, so dysphagia. So plumbers inspect clogged toilets. You can remember your triad there. Question 21, what is the first line medical management in a patient with esophageal varices? So what is the first line medical management in a patient with esophageal varices? That's going to be octreotide. It's a somatostatin analog, causes vasoconstriction of the vessels in the GI tract, and therefore decreases the vascular inflow to the portal vein and reduces bleeding. Second line option would be vasopressin, and it's very effective. It actually works just as well as octreotide, but it has a lot more adverse drug reactions, so that's why you normally use it as like a second line option. And remember, look at the vignette and make sure you're reading it, because if I said overall, what is the first line treatment for esophageal varices, it'd actually be an endoscopic intervention like variceal ligation, but I specifically asked medical management. So octreotide would be the first line medical management for esophageal varices. Question 22, what medications are used as a primary prophylaxis against a rebleed in a patient with esophageal varices? So how do you prevent a rebleed in esophageal varices? That's going to be with non-selective beta blockers like nadolol and propranolol. These are the only drugs that are recommended for prophylaxis the first time a patient has variceal hemorrhage. You're going to use non-selective beta blockers, nadolol and propranolol. Question 23, a patient with celiac disease presents to the office with pruritic papules and vesicles on their forearms and knees. What is the name of the most likely diagnosis for this patient? You should definitely know this one. That's going to be dermatitis herpetiformis. So dermatitis herpetiformis, you can take a look at what that actually looks like. Generally, it's going to be on the extensor surfaces like the elbows, the knees, and this is definitely one that you should be familiar with because you probably will be asked this. So remember that with celiac disease, anytime they mention any kind of dermatologic finding, you should be thinking of that. Question 24, what type of peptic ulcer generally improves with meals or food? What type of peptic ulcer generally improves with food? It's going to be duodenal ulcers. So the ulcer is in the duodenum, past the stomach. So the way you need to think about this, and why sometimes you can work things out in your head, is patient eats, food goes into the stomach. While it's churning in there with the acid, the stomach actually clamps down and it's not generally releasing any food or any acid for a number of hours. So during this time, the duodenal ulcer, which is past the stomach, is actually getting some relief. There's no acid coming out, irritating it. So they'll have relief for about 2 to 5 hours after meals. And that's the reason why duodenal ulcers get better with food, because of that time the stomach's kind of closed down, not putting out any of the stomach acid. And the way that I remember that is, dude, give me food, duodenal ulcers, dude, give me food. That's not my mnemonic. Somebody else came up with it, but it's a pretty good one. So remember, dude, give me food. They improve with food, duodenal ulcers. Question 25. Describe triple and quadruple therapy for H. pylori positive patients. So both triple and quadruple therapy, because you may be asked either one for H. pylori positive patients. Triple is going to be clarithromycin, amoxicillin, and a PPI. Remember, in case they say for some reason, like I had on my OSCE, they said, well, the patient's allergic to penicillin. What are you going to give them now? It's metronidazole. But generally clarithromycin, amoxicillin, PPI. And then if they want you to know quadruple therapy, that's going to be tetracycline, metronidazole, bismuth, and a PPI, like a omeprazole. And if you want a good way to remember that, this is what I came up with. So triple therapy, it's going to be CLAP. So clarithromycin, amoxicillin, PPI. And then for your quadruple therapy, I remember treat my belly pain. Treat my belly pain, tetracycline, metronidazole, bismuth, and PPI. Okay, so that's your triple and quadruple therapy. Question 26, what is the most common cause of gastritis? Most common cause of gastritis, this is an easy one, H. pylori, and then remember a close second is going to be your NSAIDs. Question 27, what diagnosis should be considered in a patient with multiple severe refractory ulcers that are non-responsive to PPI therapy? So they have multiple peptic ulcers, they're severe, they're not responding to PPI therapy. What should you be thinking of? It's going to be Zollinger-Ellison syndrome. So this is a gastrinoma. It's a gastrin-secreting neuroendocrine tumor. And it's normally found in the pancreas, the lymph nodes, the duodenal wall, and it obviously does not respond to PPI therapy because it's actually a mass, a tumor. Question 28, what is the most common type of gastric carcinoma? Most common type of gastric carcinoma is going to be adenocarcinoma in about 90% of patients. 29, 6-week-old newborn presents with forceful vomiting after breastfeeding. He displays mild signs of dehydration, and on exam there's a non-tender mass just right of the epigastrium. What diagnostic test should be used initially to make the diagnosis? Let's break down the vignette and take a look. So we have a 6-week-old newborn. It's a newborn, so we know there's certain things that are seen in this age range. Forceful vomiting. They don't just say vomiting, they say forceful vomiting. Another way to say that would be projectile vomiting. Okay, so we have this going on here. Displays mild dehydration, and it's related to the vomiting. And then on an exam, there's a non-tender mass just right of the epigastrium. So what should you be thinking in this case, and what would you use for the diagnosis? Well, the diagnosis is going to be made with an abdominal ultrasound. This patient has classic signs of pyloric stenosis. So projectile vomiting. I didn't say olive-shaped mass because I felt like that would make it too obvious, but they may describe it as a round mass, but it's generally called an olive-shaped mass, and it's just lateral to the epigastrium. And why you have that mass is you have this pyloric hypertrophy of the pylorus, so it's actually enlarged, and that's why you have that olive-shaped mass. And then, of course, the dehydration is just from the vomiting because every time he's eating, he's vomiting. And then the initial diagnosis for these patients would be abdominal ultrasound. Question 30, what patient population has the highest mortality rate with hepatitis E infection due to increased risk of fulminant hepatitis? So what patient population has the highest mortality rate with hepatitis E? It's going to be pregnant patients. So most patients with hepatitis E will have no problem. They're going to recover completely. Overall mortality rate in the general population is only about 1%. But if you have acute hepatitis E infection during pregnancy, the mortality rate goes up to about 15 to 25%. Most susceptible period during pregnancy is going to be your 3rd trimester. And really the only important thing about hepatitis E you should know for your boards is this. It's just that it has a high mortality rate in pregnant patients. The way that I always remember that was I remembered hepatitis E as hepatitis embryo to make me think of pregnancy and remember that there's a high risk of mortality in pregnant patients in hepatitis E. Question 31, what type of hepatitis virus requires a co-infection with hepatitis B to be able to replicate and survive? So that's going to be hepatitis D. And the way that I remember that is I remember hepatitis D is dependent. It's dependent on B to survive and replicate. So that's what I remembered about hepatitis D. This is what I already talked about, hepatitis E for embryo, 25% mortality rate during pregnancy, and then some of the other ones I have here. If you look at my hepatitis YouTube video, I went over all of this, but hepatitis C, chronic. So those are some other things that I remember for hepatitis to help me remember those. So question 32, patient with history of cirrhosis presents with altered mental status, slurred speech, and asterixis, which I put down what that was because I know I never really remembered. It's a flapping tremor of the wrists. What is the first line medication for the likely diagnosis in this patient? So they have a history of cirrhosis, and now they have altered mental status, slurred speech, asterixis. So the diagnosis is going to be hepatic encephalopathy, and the treatment is going to be lactulose. So it's due to the pre-existing cirrhosis. They had some triggering event. They may have become dehydrated. They may have had some excessive alcohol use, infection, which leads to this further decline of the function of the liver. Can't filter toxins anymore like ammonia. And due to this, you're going to have a buildup of toxins, in particular ammonia. And medications like lactulose neutralize that ammonia. There's some other options as well, rifaximin, neomycin, but generally those are going to be like your second line treatment. Lactulose is generally going to be first line for hepatic encephalopathy. Question 33. Which type of hernia is more commonly seen in female patients versus male patients? So which type of hernia is more commonly seen in female versus male patients? So that's going to be femoral hernias. And the way that I remember that is femoral, female. There's just a quick way to remember that. So it's due to the femoral ring being smaller in women, which makes hernias more susceptible to strangulation in that narrowed femoral ring. And also remember the way that they may try to trick you in a question, and I say this from experience because this happened to me. They may ask you what's the most common type of hernia in female patients, and that answer is indirect inguinal hernia. So that's the most common type of hernia in both male and female patients. But if they ask you which type of hernia is more commonly seen in female versus male patients, then it's going to be femoral hernias. But the most common hernia overall, male and female, is indirect inguinal, but femoral is more common in female patients. So just remember that. And again, remember, you can remember that by femoral, female. Remember that this type of hernia is more common in female patients. So question 34, what is the most common cause of viral gastroenteritis worldwide? What is the most common cause of viral gastroenteritis worldwide? It's going to be your norovirus. So outbreaks generally you'll see in cruise ships, hospitals. That's going to be the most common cause of viral gastroenteritis worldwide. Question 35, in a patient with Paget's disease of the bone, remember specifically of the bone, you can have Paget's disease of the breast, obviously look at what they're talking about. What is the first line medication class you would use for treatment? So Paget's disease of the bone, you're going to use bisphosphonates, alendronate, zoledronic acid. Zoledronic acid is actually going to be most commonly used of all of the bisphosphonates, generally the first one used in this class. And these medications normalize the increased osteoclastic activity seen in Paget's disease. Question 36, what is the most common cause of acute pancreatitis? What is the most common cause of acute pancreatitis? It's going to be gallstones. So alcohol abuse is a close second, but gallstones overall is going to be your most common cause of acute pancreatitis. Question 37, describe the triad of clinical manifestations that can be seen in patients with chronic pancreatitis. So patients with chronic pancreatitis, what is the triad of clinical manifestations? It's going to be diabetes mellitus. It's going to be steatorrhea, which is going to be like the oily or floating stools due to fat maldigestion. And then just remember when you're thinking about this, remember in chronic pancreatitis, you're going to have both decline of the exocrine and endocrine function of the pancreas. That's why you see diabetes, that's decrease of the endocrine function. And then exocrine with the steatorrhea, because you're having a decrease in those digestive enzymes. That's why you have the steatorrhea. And then finally, calcifications. You're going to have these diffuse pancreatic calcifications seen on imaging. And then finally, just remember, this is not really a common presentation. It's really only seen in advanced disease when more than 90% of the pancreas has been destroyed. So they may ask you it, but just be aware in real life, it's really only in advanced disease that you'll see it. Question 38, patient with painless jaundice, accompanied by a palpable, non-tender, enlarged gallbladder, is likely to have what diagnosis until proven otherwise? So they have painless jaundice, palpable, non-tender, enlarged gallbladder. What diagnosis should you be thinking? That's going to be a pancreatic carcinoma. So that palpable, non-tender, enlarged gallbladder, this is known as Courvoisier's sign, along with the painless jaundice. It's often seen in pancreatic cancer, and it's due to this evolving mass in the pancreas that leads to common bile duct obstruction, which causes jaundice, and gallbladder distension as all the bile's backing up. Another possibility for this type of presentation would be biliary tract neoplasm, but that's pretty rare. Generally, if you see this in a vignette or in real life, you see Courvoisier's sign, you should be thinking of pancreatic carcinoma. Question 39, what finding on abdominal radiograph would be suggestive of duodenal atresia? So you have an abdominal radiograph. What should you be seeing? What should you suspect that you'll see on the radiograph for duodenal atresia? It's going to be your double bubble sign. So we can take a look here. You have air dilating both the stomach here and then the proximal duodenum, and it's separated by the pyloric valve, and you have a double bubble, which is highly suggestive of duodenal atresia when seen on an abdominal radiograph. You don't see any gas distal to these structures either. If you did for some reason see gas pass the duodenum, you saw gas in other places, this is more suggestive of a malrotation. But a presentation like this, double bubble, gas in the stomach and the duodenum, you should be thinking of duodenal atresia. Question 40, what is the most common cause of small bowel obstruction? So small bowel obstruction, by far the most common cause, is going to be post-surgical adhesions. This can be anywhere from 55 to 80% of the small bowel obstructions caused from post-surgical adhesions, and it's attributed to these adhesions in either the abdomen or the pelvis after surgery. So that one's definitely important for you to know. Question 41. 10-month-old child presents to the ER with 15 to 20-minute bouts of inconsolable crying. This is followed by periods where the child seems to be calm and no longer in distress. That's very important for the vignette. Mother notes seeing mucus in the child's stool, and on physical exam, a palpable mass is felt in the right to mid-upper abdomen. What is the initial test of choice to make the likely diagnosis in this patient? So this patient has a classic presentation for intussusception, and ultrasound is going to be the first or your best initial test. So let's look at the vignette and figure out why this is intussusception. So first, we have a description of colicky abdominal pain. So they're having bouts of pain, screaming, crying, and then all of a sudden better. So you have this colicky abdominal pain, and then you have a right upper quadrant mass. Sometimes it can be described as a sausage-shaped mass, which would make it a lot easier, but sometimes they won't say that. But that's another finding on intussusception. And then finally, the mucus in the stool. So there's something known as currant jelly stools, and that's when stools are mixed with either blood or mucus, sometimes both. So currant jelly stools, sausage-shaped mass, and then colicky abdominal pain are all very key findings for intussusception, and then ultrasound is going to be your best initial test for that. Question 42, what test is used to make a definitive diagnosis in a patient with Hirschsprung disease? So a patient with Hirschsprung disease, to make a definitive diagnosis, that's going to be your rectal biopsy, and it's going to show an absence of enteric ganglion cells. So rectal biopsy for that. Question 43, right lower quadrant pain upon palpation of the left lower quadrant describes what physical exam test in a patient with appendicitis. So you palpate the left lower quadrant and they're having pain in the right lower quadrant. That's going to be a Rovsing sign. The way that I used to remember that for exams, it was instead of Rovsing, I remember Rosfing, and then the ROS in Rosfing standed for rebound other side, because you're palpating left and it's rebounding to the other side, the right. Or the ROS could stand for palpation in the left lower quadrant will cause pain across ROS, the abdomen, and the right lower quadrant. So that's how I used to remember that. Question 44, a persistent portion of embryonic vitelline duct leading to the formation of a true diverticulum of the small intestine is known as. So this is known as a Meckel's diverticulum, and it's the most common congenital malformation of the GI tract. So you should know that as well. Okay, question 45. What is the most commonly used tumor marker in pancreatic cancer? Most commonly used tumor marker in pancreatic cancer is going to be your CA19-9. That's your carbohydrate antigen 19-9. It may be the most commonly used tumor marker for pancreatic cancer, but it doesn't mean it's a great test. Just like CEA and colon cancer, at pretty low specificity. It's more commonly used to follow patients after potentially curative surgery to track for an increase, indicating a possible recurrence. So again, remember, if they ask you the tumor marker, it's going to be CA19-9. Doesn't mean it's commonly used or that it's a great test, but they may ask you that and you should know it. Question 46. What type of vitamin deficiency should be suspected in a patient with impaired wound healing, petechial and perifollicular hemorrhages of the legs and feet, and frequent bleeding of the gums or oral mucosa? So anytime you see poor wound healing and bleeding of the gums, you should right away be thinking of vitamin C deficiency. This is scurvy. So vitamin C deficiency, again, remember, anytime you see bleeding of the gums, tooth loss as well, any poor wound healing in a vignette, should be thinking of vitamin C deficiency right away. Question 47, the denatured hemoglobin seen within red blood cells in a patient with G6PD deficiency is known as. So that is going to be known as Heinz bodies. So we can take a look what that looks like. So Heinz bodies are indicative of oxidative injury to the erythrocyte, which is caused from the G6PD deficiency. And you can see these little inclusions here in the red blood cells, and those are known as Heinz bodies. So that's what they actually look like. Question 48, in a patient with Campylobacter enteritis, what is the first-line antibiotic class used when treatment is necessary in severe or high-risk patients? So Campylobacter enteritis, you're using an antibiotic class, so it is going to be your first line. It's going to be macrolides. In particular, azithromycin is the most commonly used of that class. Fluoroquinolones is a second-line option. And then remember, in most patients, fluid and electrolyte replacement is going to be sufficient for treatment. It's really only your high-risk patients or patients with really severe symptoms that you're going to use antibiotics like macrolides. Question 49, what is the first-line medication used for a patient with C. diff infection? So C. difficile infection, what is the first-line meds you're going to use in these patients? There's two classes or two different medications. It's going to be oral vancomycin and oral fidaxomicin. This one I always have trouble saying, fidaxomicin. So vanco and fidaxomicin are going to be the two that you use. Those are your first line agents. You may hear about metronidazole. It's another option, but really it's a second line option now. These medications have really taken over as far as first line treatment, and really fidaxomicin is actually your best option, but it's really expensive. But when it's used, it has a much lower rate of recurrence compared to oral vanco. So if it's affordable or the hospital has it, it's the better option, but these are going to be your two first line. And then remember, this is really the only time you're going to use oral vanco. Generally, it's only intravenously because it has really poor systemic absorption through the GI tract, so you don't normally give it orally. But in this case, you don't want it to be systemically absorbed. The problem is in the GI tract, so this is a perfect situation where you would use oral vanco, and really the only case where you're going to use oral vanco. Okay, so last question, question 50. Patient with Wilson's disease has an abnormal accumulation of what type of trace mineral in the body? So what type of abnormal accumulation do they have? What type of mineral? It's going to be copper. So patients with Wilson's disease, they have a deficiency in ceruloplasmin, and ceruloplasmin helps transport and excrete copper. So you have deficiency in this area, it's going to wind up leading to accumulation of copper in the body in a number of different places. The liver, the eyes, and you can get something in the eyes known as Kaiser-Fleischer rings. And this is, you actually have this copper deposition in the cornea due to the copper actually depositing here in the eye. So that's known as Kaiser-Fleischer rings. So that's one of the findings you may hear about. Probably won't see it in real life because it's pretty rare, but that's something you should be aware of, at least for the boards. Okay, so that was 50 GI questions. I hope that helped you. I'm definitely going to be doing more of these kind of in between the different sections I'm doing for the Pance. I'm going to start in pulmonology next week, and then I'll kind of put these in between every so often because I've heard from some comments, some messages I've gotten that they are helping. So I'll definitely keep making those. So thank you as always. Thank you for the new subscriptions, the comments, the likes. I really do appreciate that. So thank you so much. If you haven't subscribed yet, please do. I'm definitely trying to work on making sure I have videos out every week. And thank you again. Good luck on your PANCE, your Panre, your EORs, and good luck in PA school.